Welcome to the Zoom meeting. Today we will have 4 topics, and Dr. Mohammed and his team will be presenting some of the topics. And before we that, we will have
Hello everyone, my name is Dr. Mohammed Makkawi, leader of Team Walnut. Shall we start the presentation or after we'll wait for some time?
yes. Please go ahead when you are ready. You can. We have one of the fellows who matched and would like to have some of his tips and experience and share his perspective, his journey. So go ahead when you are ready. Thank you.
Dr. Mohammed, are you here to?
Can you hear me well?
Yes, we can hear you.
Oh, yes. Thank you, Dr. Nader, for giving me the opportunity to speak with the other fellows today. My name is Mohamed Ahmed, and I have been a fellow for maybe less than a year now. I matched this cycle into neurology. I wouldn't be talking much, just a couple of minutes. Maybe to start with, I would like to thank Dr. Nader for the opportunity to join this fellowship. It has been fundamental in my application cycle. I have been asked about what we are doing exactly in this fellowship many times. And a lot of the faculty members were very interested into understanding how this operation is going. So maybe it was the icebreaker for many interviews. I know everyone who's talking about their experience maybe is going to give you a different story. But I think from my perspective, the most important factor in my application cycle, for me personally, was the interview and the interview skills. And the presentation skills that I gained during my time in the fellowship were fundamental in how I presented myself during the interviews. And I'm saying this because many of the applications, many of the CVs of most of the applicants, they more or less look the same to some extent. And I mean, that's not bad because we are required to do the same things. What makes the true difference is how you are going to present yourself to the faculty members and to the program director. And this is something that I can admit I learned during my time in this fellowship. So I want to thank you, Dr. Nader, again, and everyone, our team leader, the Pink team. Shout out to the Pink team. Yeah, and maybe, of course, everything, there are certain things that we all know that we have to do. We have to get the exams done, get the certification, do some volunteering, and do some research work. One thing that I want to add, try to reflect either in your personal statement, maybe both in your personal statement and during your interview, an aspect of your life that is outside medicine. I have some hobbies that are related to music, and that has been always a very good icebreaker during interviews. It's very important. I think they really value to visualize the resident as a human being, and they're really interested in getting to know you outside of the hospital. Once you have conducted a very good conversation or a good conversation during interview, you make sure that, yeah, I mean, just try to reflect on who you are. What do you like to do outside of medicine? There have been interviews that I've been through. They didn't ask me about my CV, not even a single question. It was all about what artist do you like the most? What is the Sudanese music like? And They just want to visualize you being a resident for 3 or 4 or 5 years, and that you're nice, you're sweet, you're easy to work with. And I think all of these factors together maybe um, were the most important for me personally. That being said, if anyone is considering applying to neurology, I will drop my email. Please feel free to contact me anytime. I wish that I could just maybe help anyone reviewing their personal statement or letter of recommendations. And one last time, I want to thank Dr. Nader again for this opportunity, and I wish I can give back to this community even a little bit. Thank you.
Thank you so much for sharing your experience and all these tips. And we wish you all the best. So, any questions for Dr. Mohammed? So, if you can just elaborate a little bit of your experience as far as volunteering, can you share some?
Oh, yes, definitely. When it comes to volunteering, I think to be practical, the things that I did a lot of community outreach volunteering during my years in university. So I went maybe on 5, 6 community outreach programs, something that they were very interested in and talked about a lot during interviews. I worked in few non-profit organizations in Sudan before the war, and then after the war also in Sudan. I joined another non-profit organizations. And when it comes to speaking about these things, they really want to know what were your duties and what were the main reasons behind you spending your time with this non-profits. And if you are adding something, any volunteer experiences that you're adding to your CV, just be ready to talk about it in a very thoughtful way. And believe me, the way that you write things in your CV is very, very important. Maybe something that you did and you think it's not that important, or you think I just did a community outreach program for a few days, it's not a big deal. But the way that you present that experience is very, very important, and it can reflect heavily on your application. I don't know if I can name a few of the organizations that I've worked with. I don't know if you're familiar with. There's the patient support organization back in Khartoum, and Roughaia organization also in Khartoum. Both of them, they were very famous and working around the capital in Omdurman and Bahriyan, also in Khartoum. But yeah, that was mostly it.
Thanks for sharing. And one more question. Can you remember, or if you want to share one specific question about the fellowship when they ask you about it during the interview and how you responded to their question? Thank you.
Dr. Nader, that's a really thoughtful question. I think the most important question that they ask during interview is, why did you choose this specialty? They ask you, like skim quickly, like introduce me to yourself and what did you do here and what did you did there. But then they get very, like they listen very carefully to your answer regarding your choice of the specialty. If you're preparing for a couple of questions, just try to make your answer to this question genuine. Make sure you don't sound robotic, and it's always good to share something personal related to your maybe history or a family member. Just make it very personal and try to sound as genuine as possible. Why did you choose this specialty? Maybe it was the most frequently asked and the most important question during my interview.
Sounds good. Thank you so much, I don't think there is a question here in the chat. Do you have any shadowing? One more question. Shadowing experience, did you have any? You're still in Sudan or Syria or maybe right now where you are? Where are you?
Well, if you mean by shadowing like US clinical experience, I didn't have any, to be honest. I had a clinical experience in Sudan. I completed a clinical internship and then I worked for a few months as a medical officer, but I didn't do any kind of clinical experience in the United States.
Thank you so much. So I don't see other questions, but I'd like to thank you so much for sharing and your tips and advice. Thank you, and I wish you all the best, and we'll be in touch. Let us know if I can be of help or if you can help us in the future. Thank you.
Definitely. Thank you so much, Dr. Nader, and to everyone.
Have a wonderful day. So for now, we will start with the first topic on the agenda, and then we'll go to the next. When you are ready, thank you.
All right, thank you very much, Dr. Mohammed, for this valuable knowledge, and best of luck for your future. So we'll start with our first presentation about frailty. Okay, Dr. Jaffer here.
Hello, Dr. Mohammed. This is Dr. Muna, and I was in touch with Dr. Jaffer. He mentioned that he would not be able to present, so I'm ready to present the whole presentation if it's okay with you guys.
Yes, it's okay. We can start now.
Okay, hello everyone. Hello, Dr. Nader. Thank you for this opportunity. It's always a pleasure to present in this group. Congratulations, Dr. Mohamed Ahmed. Elf, elf, elf mabruk. For some reason, I like to say it in Arabic. I don't know, it feels different. I just feel it weighs more. So congratulations, and I wish you all the best. Okay, so Dr. Mohammed, you're already sharing the screen. I think everyone is able to see the screen. Okay, I think that's a yes. Okay, so the objectives of this presentation is to be able to describe why frailty is considered a clinical syndrome, clinical manifestations of frailty, adverse outcomes that are common in frail patients, most effective approach to preventing frailty, and principles of caring for frail patients. So just a simple, like easy English meaning of frailty is just being weak, like being very weak and being vulnerable to stressors. And we're going to get deeper into this topic. If you can please, I'll go to the next slide, or I don't know if I can do it from my end. Yeah, I think you have to help me, Dr. Mohammed. I don't see the screen anymore. I'll try and share from my end. Is everyone able to hear me?
Yes.
Yes, we can.
Okay. Okay, so I am able to share the screen. Can you guys see my screen?
Yes.
Okay, perfect. Thank you so much, Dr. Moon. Okay, so topics covered.
Sorry, my power got cut, so my internet crashed. You can just continue sharing your screen.
Yes, okay. Thank you so much, Dr. Makkawi. So the topics that we will cover is evidence-based findings, evidence as to cause of frailty, assessment of frailty, prevailing management strategies, potential approach for prevention of frailty, frailty and failure to thrive, frailty and palliative care. Okay, so what's the core concept? So stressors such as hospitalization, surgery, illness, or environmental extremes are less tolerated by frail older adults. As a group, frail older adults are more likely to have delayed recovery from illness and or to fall, develop greater functional impairments, including becoming disabled or dependent, be hospitalized with worse outcomes once hospitalized, including dependency, and unfortunately died. This presentation is very much straightforward, and these are the manifestations or the outcomes we see from frail older adults and more and the unfortunate outcomes that we can see with these patients. So frailty is clinically observed to be a chronic progressive condition with a spectrum of severity. I think that's one important core concept, that it's a spectrum, and it's very helpful to think of it as a spectrum during this presentation and generally in your clinical practices. The most severely frail older adults appear to be in an irreversible pre-death phase with high mortality over 6 to 12 months. So they're very prone to mortality. I don't know if I can say that, but that is one very likely outcome. Earlier phases may be responsive to treatment, either to prevent or ameliorate the clinical manifestations of frailty. So as we said, it's a spectrum. So if it's like at the end phase of it, then that's like the pre-death, and mortality can happen within 6 to 12 months. But if it's in the earlier phase, then they would be responsive to treatments, which is great. And it's our responsibility to kind of catch, in the earlier phase so that we can intervene. Primary frailty results from intrinsic aging process, and then secondary frailty exists in tandem with one or more chronic diseases. Remember this point, like when you have a secondary cause, like, if you have chronic diseases, and the first one is just due to aging. All frailty theories suggest frailty involves increased vulnerability to adverse outcomes, which may most likely manifest in the face of stressors. Regardless of cause, frail older adults have decreased reserve with which to compensate for or recover from stressors. Aggregate loss of physiologic function is the process thought to underlie the high risk of adverse outcomes. So there is a physiologic component of this condition. An emerging research agenda focuses on identifying physiologically vulnerable people before phenotypic frailty becomes clinically apparent. So we're going to know what it means, like phenotypic frailty, but just in simple words, it's what you see, like basically what you observe in a patient, and it has a criteria. So we'll take a look at it later in this presentation. But it's the physiologic underlying cause could be like the physiologic vulnerability is cooking before you see the phenotypic outcome of it, if that makes sense. Frailty is the outcome of a number of likely unrelated abnormal health conditions in an individual. So it's multimodal states, increased risk of mortality and disability. The number of conditions predicts this vulnerability. So let's say if a person has, 2 or 3 conditions, that increases its vulnerability. So they're more frail than versus, let's say, a patient that has 1 condition. Frailty is a distinct physiologic syndrome resulting from dysregulation of multiple systems. As we said, it's a multimodal state. So it's not just one singular cause or etiology. Many of these systems interact. The aggregate impact is a decreased ability to maintain homeostasis in the face of stressor, resulting in vulnerability to adverse outcomes. So baseline, they're weak. And then when you have like additional stressors, they kind of can't cope up with it. Like they don't have the normal physiologic homeostasis to cope up with stressors. Okay, so the physiologic process, according to the conception of frailty as a distinct physiologic syndrome, clinical manifestations are seen in strength, like you would see defects or like being weak, not being strong, balance, motor processing, nutrition, endurance, physical activity, mobility, cognition, cognition is it says possibly between two brackets, but the other, like the above mentioned points are like the main ones. A phenotype has been validated that links all but the last in this list. So the phenotype is the strength, balance, motor processing, nutrition, endurance, physical activity, and mobility, excluding the cognition. Physiologic process. So this is a diagram to kind of outline. So I'll start at the top here. I don't know if you can see my cursor, but at the top, chronic undernutrition. Or sorry, let's start before that. Disease, environment, medication. So these are the stressors, and they affect frail patients. Chronic undernutrition. So they would have, poor nutrition that has been going on like chronically, and then that leads to sarcopenia, weight loss. So sarcopenia is the weight loss of like the mass weight loss, the body lean weight loss. And again, there's stressors, additional stressors like medication, disease, medication, age-related change. And then that leads to decreased insulin sensitivity, osteopenia, decreased VO2, venous oxygen, and then exhaustion, decrease in strength and power. That can lead to impaired balance, falls and injuries, immobilization, and again, decreased strength and power. That can lead to decreased walking speed, disability and dependency. The decreased walking speed and disability can decrease activity. That can lead to anorexia, of aging, and decreased total energy expenditure. And the cycle continues to chronic undernutrition. So it's like a vicious cycle. It's more than one singular factor. The other thing is, I think we are privileged, or we don't really think of how old patients feel. So these things on this screen, we're just saying it as simple words, but it means a lot to older patients. Like at the bottom of the screen here, falls and injuries, that can be very devastating, really leading to disability and dependency. So continuation, yes. So this is the criteria I was talking about. It's criteria for frailty, and it has 5 components. On the left side, the characteristics. So weight loss, lost more than 10 pounds unintentionally in the last year. Exhaustion, felt last week that everything I did was an effort, or I could not get going. Slowness, time to walk, 15 feet. Cutoff depends on sex and height. And then low activity level, expends less than 270 kilocalories per week. And that's calculated from activity scale, incorporating episodes of walking, household chores, yard work, etc. And then weakness, grip strength measured using hand dynamometer. Cutoff depends on sex and BMI. Please remember this table. These are the 5 criteria. It's one of the ways of assessing. One of the ways of assessing patients for frailty. Okay. Research has shown that this construct is consistent with the definition of a clinical syndrome that is chronic and progressive. Early stage generally predicts progression to more severe frailty, but frailty can improve, particularly in early stage. Remember that we said it's a spectrum, so if it's in the early stage, then it's more responsive to intervention. Early stage are likely most amenable to intervention. First manifestations tend to be weakness, slowed walking speed, and or decreased physical activities. Many patients present without the full syndromic definition of frailty, and clinicians should be adept at constructing a differential diagnosis. Okay, there's another diagram here for the physiologic process. So here's sarcopenia, weight loss, can lead to decreased strength, increased exhaustion, decreased exercise tolerance. That can lead to motor performance, slow walking, and decreased physical activity that continues. And then looking down like at the molecular level or at the level of the cell, the physiologic dysregulation can lead to cellular dysfunction, molecular and genetic characteristics, and that can also affect the physiologic dysregulation. So these two affect each other. And then this can affect physiological mobility and decreased motor slow walking. Okay, so sarcopenia, loss of lean body mass, is the central component of frailty and the key predictor of the other clinical manifestations. So when we get this as a symptom, it's like a red flag, and hopefully it will remind us to think of frailty. Predictors of sarcopenia and loss of strength with aging include decreased anabolic factors such as testosterone and IGF-1, insulin-like growth factor 1, diminished physical activity, reduced nutritional intake, example, protein, energy, vitamin D, and other micronutrients. Older age by itself is a factor. Okay, although the fundamental underlying cause of frailty is still unknown, the intermediate process appears to entail the dysregulation of inflammation, indicated by the increased IL-6 and CRP, the interleukin-6 and C-reactive protein, decreased immune function, anemia, increased glucose intolerance, insulin resistance, low levels of DHEA, S, and IGF-1, increased cortisol, low testosterone, decreased heart rate variability, nutritional derangements. The number of abnormal systems is a stronger predictor of the syndrome of frailty than dysfunction in any one system. So as we said, it's more than one. It's not one singular etiology. It's more of multiple systems being affected, and that's a stronger predictor than just having one system being affected. Okay, secondary frailty. A variety of primary disease independently predict development of the frailty phenotype, potentially through inflammation and or their effects on cardiopulmonary function and inactivity. Immune disorders like HIV and AIDS, heart failure, COPD, chronic infections. So these could be the underlying diseases or like the primary diseases that a patient has and cannot take more, can be one of the reasons why a patient can be frail and cannot cope up with stressors. Okay, so the assessment of frailty. Screen patients for frailty too. Identify those at risk of adverse outcomes. Gauge the severity of risks. Find those who may benefit from prevention or treatment. Track change in status over time. Determine eligibility for palliative care for those at end stage. The cumulative number of symptoms, signs, illness, and disability presents is useful to categorize, aggregate morbidity burden. So as we said, again, it's not one single etiology, and the more abnormalities or the more conditions you have, the more you can identify where the patient is on the spectrum and hopefully be able to do something about it if it's in the early phase. Okay, so ways to assess frailty. I think this is one of the important things we need to know as physicians. Assess number of phenotypic frailty criteria present. Remember the table I showed you earlier, the criteria. It had 5. So out of 5, like what does this patient have? Is it weight loss? Is it exhaustion? Low activity? Slowness? Or I think the last one was the hand grip, like the grip strength. So out of that, what does the patient have and how many? So that's the first point here. And then rapid screening assessments that have been validated, such as the interview-based Frail scale. So if you realize the first point or the first way of assessing the phenotypic frailty is basically what you see, and it's more of like the physical assessment. While the second one is an interview, it's like the patient would tell you, like it could be question, like the interview questions could be like nutrition, or if they have existing illnesses, like physiologic wellness, or like social let's say, social support, if they have any of the social support, which is very important for older patients. So it's more of, like an interview versus the first one. It's more of like more numeric, like number-based assessments. You just count out of 5. Weight loss, how much did he lose in the last, he or she lost in the last year. It's more of numbers, while this one is an interview. And then the third one is clinical global impression of change in physical frailty. That's CGICPF, for frailty as a clinical composite or gestalt, which I actually Googled this word. So it basically means the clinician or the physician looking at the patient as a whole, like not taking one. Even from its name here, it says clinical global impression of change in physical frailty. So it's taking the patient as a whole and looking into everything as a whole. And then it's actually a what do you call it? A clinical trial. So you follow the patients and see like what, if you've done any intervention, have they improved after a period of time, if they've improved or not, like did they change work or not. So it's a global impression of change in physical frailty after an intervention. And then walking speed or grip strength, that's one of the early manifestations of frailty syndrome. And that's included in the first point, the 5-point assessments, the phenotypic assessments. Comprehensive geriatric assessment and management is designed to optimize outcomes for frail older adults, particularly preservation of their independence, which is very important. I think everyone would agree. This team-based multidisciplinary approach has positive effects on polymorphisy, falls, functional status, nursing home admission, and mortality, all of which is very, very important for old patients and frail patients. Should be coupled with accurate screening for frailty and ongoing expert geriatric care. Okay, so managing frailty, the focus of care should be to exclude any modifiable precipitating causes of frailty, including causes that are treatable or environmental, improve the clinical manifestations of frailty, especially low physical activity, strength, exercise tolerance, and nutrition. These are the things that it's kind of in the patient's abilities or the physician to encourage patients. These are the things I feel like like the patient and the doctor can work on together. And those are one of the important issues to tackle. Like the second point, the physical activity, strength, exercise tolerance, and nutrition. Even sitting on a chair, like exercising, even sitting on a chair, mobility is an issue. Those simple exercises would make a great deal with older patients. Minimize the consequences of vulnerability, whether in terms of environmental risks of from low social support, or risks from stressors such as acute illness or injury, hospitalization, or surgery. The approach that older adults use to adapt to age-related physiological losses and behavior can also be applied to frailty. So it's important to carefully choose goals. We have to understand that there may be some limitations, and we should carefully choose like what is our goal, and then optimize the abilities needed to reach these goals, compensate for diminished competencies by increased reliance on other functions or by replacements. A simple example that I can give is, let's say if a patient is so weak, so frail that they really cannot walk, then they use a cane or they use like supporting equipment or instrument. And if their lower part of their body is really weak, then they try to depend or use the upper part of their body more. That can be one example. And to kind of teach them, different ways to increase reliance on other functions or by replacements. Clinical management should include such approach for care of frail older adults, as well as more standard medical approach. Okay, so potential prevention of frailty. points of vulnerability or recipients. Exposure to any of a variety of stressors appear to put frail older adults at risk of adverse outcomes and potentially to precipitate frailty in those already at risk. So key potential precipitants are immobility, that's a big one. It might accelerate the onset of dependency, and then depression associated with decreased activity, energy, nutritional intake, inflammation, and social isolation. Appears to be an outcome of frailty as well as precipitant. So it's like a double knife. Hospitalization and surgery. Attention needs to be paid to minimizing these precipitants and or the stressor associated with them. Okay, what are the pharmacological treatments? It has not been demonstrated that replacing deficiencies of any one hormone can prevent or ameliorate frailty. So we mentioned earlier that they could have some decrease, some hormones are decreased in their body, and replacing those deficiencies did not show to be helpful. The number of deficiencies in multiple physiologic systems more strongly predict frailty rather than the presence of any one deficit alone. Future effective drug treatments will likely be those that target multiple systems simultaneously. A key approach, along with comprehensive geriatric assessment and management, has been shown to decrease polypharmacy and related adverse medications, even in frail older adults. Okay, maintaining physical activity and muscle mass is critical in older adults at risk of frailty. Resistance or strengthening exercise is effective in increasing muscle mass, strength, and walking speed in frail older adults. Other forms of exercise, including strengthening, Tai Chi, or Chai, I don't know how to pronounce this, and aerobic exercises are also helpful. Preventing immobility is critical. Okay, and then the behavioral approach. Consumption of Mediterranean diet has been shown to lower the risk of becoming frail over 6 years in community dwelling adults more than 65. The Mediterranean diet is the healthy diet, I think, less of red meat, more of vegetables and fruits and those kind of diets. Attention to preventing nutritional inadequacy is important, including supplementation of protein, calories, and micronutrients. And then in many studies, nutritional supplementation appear to be effective only when added to exercise. So as we said, exercise is a big part of trying to tackle frailty. And the nutritional supplements appear to be effective only when added to exercise. Okay, failure to thrive and frailty. So failure to thrive was historically a diagnosis applied to an older patient with severe symptoms that have no apparent cause. Some experts believe the term should be abandoned because it does not assist in thoughtful evaluation. Some argue that a term initially used to describe delayed development in children is pejorative when applied to older adults, like inaccurate or does not give, it's not used well when it's used to describe older adults. Conceptually, there may well be overlap between the concept of failure to thrive and very severe or end-stage frailty. Okay, frailty and palliative care. Frailty predicts functional decline and onset and progression of dependency at the end of life. Severe frailty with a score of 4 to 5 and metabolic abnormalities of low cholesterol and albumin predict particularly high short-term morbidity rates in frail older adults. A clinical case series suggests a poor response to treatment in those with end-stage frailty. It may be appropriate to consider palliative approach for these patients. Okay, so we appreciate the summary. Frailty appears to be a clinical syndrome of dysregulated energetic energetics with different definable clinical manifestations that become apparent when physiologic dysregulation reach the critical threshold, and the end with recognizable causes at the level of both altered physiological and potential altered genetic, cellular, and molecular processes. Validated frailty syndrome is manifested with 3 or more of 5 phenotypic components are present, which are weakness, slowed walking speed, low physical activity, low energy or exhaustion, and weight loss. Frail patients are at high risk of adverse clinical outcomes, including falls, disability, disability and dependency, and mortality. Frailty develops along a continuum of severity, likely including a latent phase that is not clinically apparent in the absence of stressors, early stage likely most responsive to intervention, and the late end stage that indicates a high risk of short-term mortality. The most effective preventive approach that appears to be maintaining muscle mass and strength and consuming a Mediterranean diet. Okay, so this is the end of the presentation. There are 3 questions. So an 80-year-old woman is admitted to the hospital for treatment of uncontrolled hypertension. So she has one chronic illness. She describes long-standing fatigue and poor energy, history of more than one, so lung disease, heart failure, aortic aneurysm. During routine screening, the aneurysm was noted to have increased in size. She has lost 3 kg in the last year. Examination, hospital day 3. Her heart rate was 60, blood pressure was 160/70. The BMI is 18 kg per meter square. She has difficulty rising from the chair. Her gait is slow. Okay, so this is the patient. For which one of the following does her frailty put her at increased risk during the hospital stay? If you can answer in the chat. So A is extended length of stay, admission to ICU, exacerbation of heart failure, higher mortality. So far I see A's and B's. Extended length of stay and higher mortality. Okay, so the answer is D, higher mortality. If we go back to the, like if we can apply the scale, she at least has 3 of the 5. Her weight loss, and then she's having weakness, difficulty rising from chair, and her gait is slow. So these are 3 out of 5, and that puts her at towards the end of the spectrum, and that could lead to mortality. Okay, the second question, which of the following is the most effective frailty screening for use in clinical practice? Is it self-reported health, gait speed, polypharmacy, assessment of general practitioner? Okay, we talked about means of screening patients, right? Like our tool, one of the tools we use to assess patients, and we kind of grade them. So which one of these is one of the criteria used to grade or scale the patients? Which one of the following is the most effective frailty screen for use in clinical practice? Okay, so the answer is not polypharmacy, C, no. Which one of these is in the scale? Like D5, the table. Yeah, B. So it's the gait speed. It's one of the effective frailty screening methods we use in the clinical practice. So the answer is B, gait speed. Which one of the following intervention is not endorsed by a consensus of experts regarding treatment of physical frailty? Is it calorie and protein supplementation, hormone supplementation, vitamin D supplementation, reduction in polypharmacy? And it says not. So which one of the following is, intervention is not? Which one of these is not helpful for frail patients? Okay, I see B's and D's. Yes, the answer is B, hormone supplementation. It's found that it's not helpful for patients, for frail patients. Okay, I think that's the end. Thank you so much for patiently listening to me. I hope this presentation was helpful. I will stop sharing and hand it over to Dr. Makkawi.
Yes, thank you very much, Dr. Amuna, for this presentation.
Thank you, Dr. Mona, for a great presentation. Any questions?
If there is any questions, you can put it in the chat box.
Excellent. Thank you so much. We can move on to the next item on the agenda, research bias.
All right. Thank you very much. My name is Dr. Mohammed Makkawi, the leader of Team Walnut. I'll be talking about research bias. Okay, so what is research bias? So we'll talk about what is bias in general. So if there is any tendency that we try to change consciously or subconsciously a result in order to reach the result of what we want, this is known as bias. So in research, bias occurs when systemic error is introduced into sampling or testing by selecting or encouraging one outcome or answer over others. This is in order to achieve the result that we want. So it can occur at any phase of the research. It can start even pre-planning before the research, during the data collection, as well as after data analysis and publication. This is unfortunately, no matter what we do, there will always be some degree of bias. So readers must also consider how bias might influence a study conclusion. So this graph, which just summarizes the major types of bias in clinical research. There are some that in the pre-trial, like float study and selection bias and channeling. And during the trial, like interviewer bias, recall bias, and during data analysis after the trial, like citation bias and confounding. We'll be focusing on three of each of pre-trial and during trial and after trial. Okay, so in the pre-trial bias,
They include errors in study design and patient recruitment. They usually can cause fatal flaws in the data and which cannot be compensated during data analysis. So in order to avoid this, we mainly have to go with a proper, we'll come back to it later, on how to prevent such types of bias. So they include selection bias, flawed study bias, and channeling bias. We'll be focusing on selection bias here. So what is selection bias? It usually occurs during the identification of the population. So when we identify a certain population during our study, this occurs when the criteria used to recruit enroll patients to studies are inherently different from those in the other cohort. This is particular problem in case control and cohort and retrospective cohort, because usually in these studies the outcome is already done because we are looking retrospectively. So the exposure and outcome has already been occurred, so it by itself can cause bias, selection bias. Usually prospective studies such as prospective cohort or randomized controlled studies where the outcome is unknown, they usually are less affected by selection bias. So from here you can see in this this picture, for example, we have this population containing these green and red men. So when we start collecting sampling from this population, selection bias occurs when we focus mainly on the red men rather than the green men, instead of taking a proper randomized selection of both red and green men. So then we're going to go to bias which happens during the clinical study. This is also known as information bias. It's a blanket classification of error where bias occurs in the measurement of an exposure or outcome. This information obtained and recalled from patients in different groups can be unequal in some ways. There are many types, such as recall bias, interviewer bias, patient loss to follow-up, bias from misclassification, and so on. I will be talking mainly about the recall bias. So what is recall bias? It usually refers to the phenomenon in which the outcomes of treatment, either good or bad, may color subjects' recollection of events prior to or during the treatment process. One common example that is always used, even in lectures, is the perceived association between autism and MMR vaccine. So what usually happens in recall bias? Those mothers of children who have autism are more likely to recollect the event more than those who don't have autism, more than the mothers who don't have autism. Another example will be, which is easier to follow, is association between deficiency in folic acid and neural tube defect. Mothers who have children with neural tube defects are more likely to recall, yes, before when I was pregnant, I did not take folic acid, that's why my child has neural tube defect, more than the mothers of children who do not have neural tube defect. So recall bias most likely occurs when there is exposure and disease status are both known at the time of study and can be problematic with patient interviews. So in order to help reduce this, we usually do a specialized structured interviews in order to avoid leaning towards one particular answer compared to the others. So this diagram will summarize usually those cases that recall past exposure more than the controls. And the controls tend to underreport their past exposures. So you can see here the A, which is usually the case reported by the exposed, is more, and D, where the controls with the case exposure not reported is decreased, which leads to increased odds in case control studies. Okay. Then finally, we have the bias after a trial. This usually occurs after the data analysis or publication. They include citation bias and confounding. We'll be focused on confounding. This usually occurs when an observed association between exposure and outcome interest, but there is a third factor that is independent that is usually associated with both the interest and the exposure. common example seen is when you're trying to do a study and then we wish to check if there is any association between coffee drinking and heart attack. This is usually confounded by the fact then we will find that there is increased risk of heart attack among those who drink coffee. But once we stratify it, we find that those who drink coffee are actually more likely to smoke. And smoking is the reason why there is actually a higher association of those drinking coffee compared to those not drinking coffee in order to develop heart attack. You can see in this diagram here, the exposure here is the coffee, and our result is cancer. So when we do the study, we find that there is an association between coffee and cancer. But we fail to think about the confounder, which is the smoking, which is usually associated with those who drink coffee, which is actually the one that causes cancer. So we talked about the various types of bias. So how do we reduce bias? Well, we can start from the beginning when we start doing the study design. So when we try to take collect our sample, we should do proper randomization and randomly assign participants to help reduce selection bias and ensure both groups of both sides are comparable. Another level what we can do is blinding, especially if we are doing a randomized control trial. When we do a control trial, we have to do the standard of care is doing double blinding. We blind both the participants and the researchers. So this will help. This will prevent experiment or participation bias. Another thing we can do is to have a clear study design. If we have a strong, well-defined research question, target population, and sampling methods, they can reduce ambiguity and potential biases. Then during data collection analysis, many of the questions usually, especially in the qualitative studies, they are done in the form of questionnaires. So in order to avoid data collection bias, we should use clear and unbiased language in surveys in order to minimize response bias. And then usually we always collect, when you collect the data, we always do it anonymously, so in order to reduce social desirability bias. Then we also when we do a study, we should always have a diverse sample, which is a representative of our population. So including diverse groups of population will ensure the findings can be extrapolated to a wider population. Then researcher awareness. One of the things that we should always keep in mind that we always have bias. We should always be our research should always be aware of their own bias and potential influences on their work. Another thing we can do is peer review. We can take our data and we can let other peers, other researchers to check our work to see if there is any potential area of bias. And then transparency. Many times you can see, if you find in the literature, you will find at the end, like they usually declare it as a form of transparency. Like they may have study methods, there may be any limitations in study methods, or potential sources of bias that can enhance one particular result over other. And accountability, they're usually mentioned towards the end of the research. So this is very important to be mentioned when we are doing our study. And that is all. Thank you very much for your time. I hope you have enjoyed this short talk. If you have any questions, you can post it in the chat.
Thank you so much, Dr. Mohamed, for excellent presentation. And it's also an important topic. If there is no more questions, we can move on to the next item in the agenda. Thank you.
Just give me 1 minute. I will share the screen. There's some issues with my phone, okay?
Assalamu alaikum. Hello.
Wa alaikum salam.
I hope you're all doing well. Dr. Mohammed, if this is the presentation of the apps, I can share them. I have my laptop open.
Okay, you can share it with yours because I have some issues with sharing. You can share it with your.
Okay. Can you see my screen?
Yes, we can see it.
Okay. Hello, everyone. My name is Amna Eisawi. I am a part of the Indigo One team. I am a general practitioner and a alumna of the Roughaia University, Sudan. Today, I'll be talking about apps that could be used by residents, specifically BGY1s. I'll be giving some suggestions, talking about the general apps or the mostly used apps across different specialties, and then giving some suggestions for apps that are specific for certain specialties, and then I'll give you some suggestions on how to look for further suggestions. Now, we all know that the BGY 1 year or the first year of residency could present with significant challenges, clinical-wise and knowledge-wise. So mobile apps would assist you in having better decision-making or faster access to up-to-date data and better kind of a way to manage the overwhelming responsibilities that are present in the first year. The mostly used apps, as I could find online, were the infamous UpToDate app, and then the MetCalc, which is very useful with looking for different criteria and calculations that are important. There is also the UpToDate Lectodrug app, which is basically an application that talks about pharmacology. Not talks about pharmacology, but it kind of helps you in terms of dosing and in terms of giving the medication and so on. There is another app that's alternative to the Lexodrug app, and that's the Sanford Guide Antimicrobial application. Okay, so I'm going to start with the UpToDate application. I would assume that a lot of people know about it. It's extremely famous and it's very important. I would say in terms of how much of a value it gives. It's an evidence-based clinical reference tool. It offers detailed information on disease diagnosis, treatments, and guidelines. Here's a picture of how the interface looks. You could obviously here search on certain topics, and then you could also bookmark some of the topics if you find yourself going back to a certain topics multiple times. The application is, as you can see, very nice. It basically divides the sections into an adult section, pediatric section, and then a section that talks specifically about the patient and their presentation and so on. When you enter into a specific topic, you would find all of the outlines in a sidebar, so you can move quickly into the specific section that you want to check. It's available on App Store. It's also available on Google Play. However, the app is paid, so mostly for UpToDate application, you would have to check if there is institutional access. So some of the residency programs would provide access to UpToDate and some other applications or services throughout their institution via the institution email. So check if the institution has UpToDate. Otherwise, if your institution does not provide it, you would have to pay for it. Okay, the second application that I think is very important as well for interns that I have personally used throughout my internship is MetCalc. Now, MetCalc contains numerous medical calculators and scoring tools. you would go into the app, which this is an example of the interface. You would search the specific score, calculating, if you want to calculate some of the electrolytes, you want to get corrected electrolyte calculation, or you want to, for example, calculate a certain score, like the CHAD-VASC score. You would need to, type the whatever you are searching for, and then you would find the options here. They will pop up. You would go into the application, and then after opening up the specific score that you want to calculate, you would find the calculator section, in which you would be entering informations basically into the into a specific subsections or questions here, and then the app will calculate the score for you. It does, it's very useful. It makes the process of assessing certain scores very easy. And after that, you would look into the you can look into the next steps subsection, in which you would know what usually is the criteria for whatever score that was calculated. It also gives a subsection that talks about the evidence. The MedCalc app is free and it's available in the App Store. It's also available on Google Play. It's very useful, and I think it's one of the important tools to use, especially if you're working in a clinical setting. That's being pediatric, neurology, internal medicine, whatever, mostly for clinical subspecialties. The third app I will be talking about is the up-to-date Lexidrug app. As you can see, it's basically a comprehensive drug reference to go to if you're not sure about the dosing of certain medication, if you want to know about the interaction, the renal or hepatic adjustments for the renal dose. As you can see, here is an example of how the interface looks. It's very simple, and you would search about the certain medications here, and then you can also bookmark if there's a certain medication that you find yourself going to, that you find yourself checking often. You can bookmark them. You can calculate the dose, see their interaction, and so on. Okay. An alternative for the up-to-date Lexidrug application, because again, the up-to-date applications are not for free. So if your institution does not have institutional access to those applications, you can check other apps. The Sanford Guide antimicrobial application is a quick access app that's also beneficial if you're looking into apps that would help you with the dosing of certain medication. However, it's specific to antibiotics. It will help you with antibiotic selection, resistance patterns, and pathogen-specific guidelines. Here is an example of how the application interface looks. You could look into the specific pathogens, the specific medications, and so on. Yes. Here you would find your bookmarked antibiotics, the calculators, and so on. It's very important to put in mind that when you choose an application, to make sure that this application complies with the guidelines that are specific to the country you're working in. So if you're working in the United States, make sure that the application has the guidelines that are specific to the United States. If you're working in the UK, for example, or Ireland, or another country, it's important to check that whatever application you're using, it goes well with the guidelines of this specific country. Okay. This is one of my favorite applications. It was the holy grail, basically, of my emergency medicine rotations. The Wiki EM, which is now included in the EOLAS medical application. It's a quick reference guide for emergency medicine. It has it also includes other tools such as the MedCalc application. You would basically, once you download the application, you would go into this knowledge section, and then you would find the Wiki EM. Of course, there are other valuable tabs, such as the NICE guidelines and the medications, in which you can even check for the British formulation guidelines, the BNF. However, the tool that I want to speak about is this WikEM tool. It's an extremely valuable tool. You would go into the WikEM and then choose whatever topic you want to check. It's directed for the emergency medicine, specifically for emergency use of emergency medicine physicians or residents. However, I believe that even medical students, maybe to some extent, IM residents would benefit to a degree. It basically gives you a comprehensive and summarized, basically section of the diseases or the specific topics that you want to know more about. It's specific for emergency medicine, so it starts from giving you an introduction about the disease, the pathophysiology, gives you differential diagnosis, all of the diagnostic tests that you would need to do. It gives you any criteria that you would want to know, any imaging findings that you would want to look at, and basically tells you where to let the patient go, whether the patient is to be discharged, and if the patient needs to be discharged, what's the criteria for discharge, if the patient needs admission, and if the patient needs specific consultations. So it's a very comprehensive and it's a very good app for your emergency medicine rotation. And even if you're a medical student, you could benefit from it. It's one of my favorite applications. It's also free, which is really a good additional kind of, it's a good additional benefit to the application that it's free. Now, of course, the most favorite one is the UpToDate application when it comes to reviewing topics in general, but WikEM is, in my opinion, a really good free alternative if you don't have access to UpToDate. Okay, so here are some honorable mentions of some applications that you could look into. For the OBGYN specialties, you could look into the ACOG app. And generally, for each subspecialty, you could look and see if the physician association of your specific specialty has an app in which they have their guidelines, which you could use. For OPS as well, you could, for obstetrics and gynecology, could also look into the calendar apps, which are used to calculate the LMPs and the last menstrual period, and basically it gives you the calculations of how many weeks is this pregnancy. It's very useful to use, and it's very useful to have in hand as it makes life much easier. The pediatrics specialty, you could download the BD Stat, which is basically kind of it's just for the calculations and the measurements we have to do when taking the measurements of the children. It just gives you a very easy to access tool instead of checking different guidelines and different graphs and graph graphs and so on. It kind of has all of that in one application. Other tools that you could look into is tools for your board exams. So if you're in family medicine, you can check the American Board of Family Medicine Exam Prep app. If you are a internal medicine resident, you could look for the UWorld packages for the internal medicine exams to prep. And you could also use Anki, the infamous Anki application, etc. These are just examples, but it would also be beneficial if you want to revise something and kind of study for your board exams. Maybe it's not as important for the BGY1s, but it's also important to put in mind. Now, some other miscellaneous applications that could be used regardless of your specialty and that are not specifically academic applications or applications that are intended to be used clinically. There's the EPIC, or if there's any application for the electronic medical record system that your hospital uses, you could have that on your phone. Any note-taking app would be a lifesaver instead of having a physical notebook with you. YouTube, of course, if you want to look into quick videos on how to do certain procedures on certain topics, etc. There are other options, obviously, but these are the ones that I thought were really important to mention. Okay, so now we have known the applications that are used in most specialties. As we said, the UpToDate Medicine, the LexiDrug app, and the MedCalc application, also the WikiM application, and some other options as well. Now, if you want to look for further suggestions that are specific to your specialty, and if you want to look into important applications, here are some suggestions that I would like to give you on where to look. First of all, you could check the Reddit, the subreddits. If there is for example, a certain specialty subreddit, like the pediatric subreddit, you could ask there. You could also ask in the residency subreddit. You could look for threads, the previous threads, which were, I used some of the threads on Reddit, on the residency subreddit, to prepare this presentation. They do have, and people there give some, what I think is really good advices. Sometimes you could also check on the student doctor network forums. I think the most important, or in my opinion, the most important one, is to ask your senior residents. And generally just ask in your program what's the recommended applications to have on hand. And of course, again, ask what are the applications or the certain tools and basically clinical tools and any clinical tool that you could use that the institution provides. Okay, everyone, thank you very much for your attention. That was a very brief presentation about the applications that are mostly used by residents, or that are helpful for residents. If you have any questions, or maybe if you have some more tips or better suggestions, please feel free to do so. Thank you very much.
Thank you so much, Dr. Anna, for an helpful, great presentation. I hope this will help some of you when you join the residency. Any questions or any updates or anything to add to Dr. Anna's presentation?
Thank you, Dr. Nadir. I hope everyone benefited.
Dr. Roughaia, can you do screen share for your topic? I'm still having trouble doing screen share with my phone.
Okay, yes, Dr. Mohammed. Thank you. Hello, I'm Roughaia Mohamed. I will share my screen now to present the quality improvement topic. Just a minute. Hello, did you see my screen?
It was working just now, but now we can't see it.
And you didn't listen my voice yet, right? Okay. Okay, we'll try again.
Okay, now we can see the slide.
Dr. Roughaia, you are muted.
Okay, now can you listen to my voice?
Yes, we can
Hello?
hear you
Yes.
now.
Yes, okay. So I will start again. I'm Roughaia Mohamed, I'm medical officer. I'm glad that you are hearing me and listen to me. So first, I will talk about the introduction about quality improvement and patient safety. Both are essential pillars for modern healthcare. The aim is to reduce the errors, improve the outcomes, and provide the safe and effective care for every patient. So, um, first, we have to identify and address the system errors. What are the system errors? They are a failure in process or workflow, not just individual mistake. For example, the poor communications between the team member and lack of protocols and shortage of equipment or delay. How we can identify the system error? First, we have to do we can do incident report and root cause analysis. We can do root cause analysis by different tools. Some of it are the fishbone tool, and the next also we can identify by safety workarounds. Then we have to do the solution to address these system errors. We can redesign protocols and workflow. We can improve the training and clear communication between the team, and we can reduce the reliance on memory. We can use the automated system. For example, a medication error occurred due to similar package of two drugs. So after several reports and the hospital introduced the color-coded labeling and conducting staff training. As a result, similar error reduced by 70%. So this is one of example of system errors. Next, we will talk about how we can participate in quality improvement initiatives. First, the definition. It's a continuous process that use data and teamwork to improve the healthcare delivery. The tools, common tools for this, it's plan, do, study, act cycle. I will show an example in next slide. And also we can do a key performance indicator and process mapping. So this is an example of plan, do, study, act. This is another, we can replace the study by check. So first you have to identify the issue, then to plan to solve the problem, and then try the solution and see if it's work, and then you have to check is it work or not. Then you have to adjust your plan and the cycle around again. So next, ensuring patient safety in practice. This is an important pillar here in quality improvement. The principles are confirm patient identity before any procedure and clearly explain the treatment plans to the patient. Also, you have to encourage incident reporting without fear of punishment to detect any errors. So the team rules. should be effective communication between the team member and open communication. Also, we have to promote the safety culture, and we have to use the checklist. For example, of the checklist, this is a WHO surgical checklist. This checklist have to confirm the patient identity, surgical site, and the procedure to overcome the errors, and it's used significantly reduce surgical complications and mortality. In conclusion, everyone shares responsibility for quality and safety. By identifying errors, engaging in quality improvement, and promoting safety, we can improve the healthcare outcomes and protect patients. Thank you. So, do you have any questions?
Thank you so much, Dr. Roughaia. Any questions for Dr. Roughaia or any of the presenters? If not, we can move on to the next item in the agenda. Any updates or any new ideas, questions? I know some of you are working on different projects. So I'd like to ask any of the new fellows if you have any questions about the program. Please go ahead. Any
No
ideas from any
questions. Thank you very
no
much.
questions? Go ahead. Thank you, Dr. Um, any suggestions for improvement during these sessions or in the program in general?
Assalamu alaikum, Dr. Nader.
Alaikum salam wa rahmatullahi. How are you?
Fine, thank you so much. I have a proposition about a presentation. If you would like to do this kind of presentation, it's about a case review. It's an evidence-based, so we can have a case and we can do the management on evidence-based management. So if you are okay with that, I can start by one. So
Yeah.
I can.
Sure. You have a case?
Yeah,
Sure.
we can have a case and then we can make a presentation where we can every step in management would be evidence-based. So we can review the guidelines and any new recommendation about every such step.
That would be great.
Okay,
Sure.
thank you.
Thank you so much, Dr. Sting. So we'll keep in touch and let me know when this will be ready for the future meetings. Thank you. Any one of you started on joining a project where there is a mobile application development. Dr. Randa, please go ahead.
Assalamu alaikum, Dr. Nadir. Hi, how are you?
Very good, alhamdulillah.
Alhamdulillah. How are you, everyone? My name is Randa Hassan. Very thank you, Dr. Nadir, for this great opportunity. And thank you all the presenters for the great and informative presentations. And I want to update you regarding our mobile application, which we named Smart Diabetes Control. Actually, we have gone through all the development steps from planning, implementation, and also internal testing. And the last thing did is close testing. After we did, we received an email that for congratulations that we completed the close testing successfully, and we can apply for production. After I go through the steps for production, I receive another email that mentioned that there is a mismatch between the declared app features and the actual health content. And actually, I received this the similar email before when I did the internal testing. And at that time, I just remove some features, and there is like fitness, educational topics, disease management, and something like that. I omitted and just choose there is option others, and I just write it down about the application, because I know that the last year there is new requirement for the applications, especially health application, which mentions that there is some feature need an organizational account, and actually we just use my personal account for that. Now I received this, and at that time, just when I omit the declared feature and write down about our application, they accepted and we move forward. But this time again, they sent us the same email that mentioned we have to declare it probably. And what I think actually this if I use any of these features that will need to submit our application under organizational account, and that also need legal business documents. So actually this that's what we face now, just this issue. Before the app will be available at Apple Store, at Google Store. So I need your advice.
Sounds good.
If there is anything that we can do it.
So congratulations, you went so far. So it's good that you reached to this point. As far as the mismatch, what I would suggest, we have two options. The first one is to do what you did in the past, like you do review the list and the features that are not there in the app, you can remove it, or you can mention it in the future if you want to add that as next version will contain something like that. But at this time, I think it's better just to remove them. If they are not in the app, they are not functioning. On the other side, if you have some of the features ready, you want to include them in the app, and you want to get an organizational application, we can do that through the organization that we have here. We have the Combined Research Foundation. It's a new program, but it's established here in Michigan with the government, and we are like waiting for non-profit status from the federal government, so they will give us an ID. But we can go ahead with the ID that we have from the government currently, and we can take it from there. So as far as paperwork or documentation that are needed, we can help you with that. So which direction you want to go, I'd be happy to help you. Thank you.
Yes, thank you, Dr. Nadir. Yeah, that actually just I think those the only two options. The app actually now it is ready. We did all the features, but if we want to go with individual account, we have to omit the all educational topic, and that actually most of my team work on it. That I feel like want to remove it, as they did a lot of effort and put it on it. But if we can move with just with individual account, we can omit that, and also don't mention also the medications. We can omit it also, and I think that we can it be ready to submit it again.
So whichever you decide on your team, I'll be happy to help as much as we can. If you think that's the right thing and you want to do that, that's absolutely okay. And in case you decide to go through the foundation, we can work together to submit it through the foundation and take it from there.
Okay, we'll do that. Thank you so much, Dr. Nadir.
Thank you so much.
Thank you, I appreciate it.
And your team. Yeah. Any other questions or any other comments, suggestions, ideas, or new projects? If none, then I'd like to thank you all for attending this meeting. Thank you for a great presentation, all the presenters from today's meeting. And thank you, Dr. Mohamed, for moderating this session. If you have any questions, please reach out, and I'll be happy to answer any. You can email me or send me a text or call. I wish you all the best, guys, and we'll see you next week. Assalamu alaikum.
Thank you, Dr. Nad.
Thank you, Dr. Nadir.
Thank you very much.
Thank you. Alaikum salam. Thank you so much.